And then I'm just going to share my screen.
Hi, your finance reporter David Chow.
Inflation fell from 4.6% in March down to 4.2%.
And I just want to make sure that
the
everybody can see my screen there.
Yep.
Everybody can see the screen, okay?
Yes.
And when I click on that, you can see that, okay?
Yes.
Okay, so now, if I just click that, can everybody see?
Yes.
What the idea of the talk is?
Yes.
Okay, that's good. So I'm going to mute everybody now, and then I'm going to talk, and then, as I say, we'll come back to any questions at the end. All right, so everybody's now muted. So, all right, I'll just play my. There we go. All right, so thanks everybody for coming. My name's Peter Sharp, physiotherapist at St Leonards. We're just going to talk about knee and hip osteoarthritis today. The first part, we'll just go through some of the anatomy of the knee and the hip. Then we're going to talk about what is osteoarthritis. Then we're going to talk about how is it diagnosed, how do you know if you've got it. Then we're going to talk about what treatment options are there available. And then we're going to talk about exercises and the GLAD program. So as I say, we'll try and move through things pretty quickly so there's plenty of time for any questions at the end. All right, so the first thing to talk about is the knee joint and the anatomy of the knee joint. And the knee joint is what's called a tri-compartmental joint, which means it's got three separate parts to it. So there's a inside part of it called the medial compartment, the outside part of it called the lateral compartment, and then there's a section under the kneecap which is called the patellofemoral compartment. All right, so you can have problems with one compartment, two compartments, or tri-compartmental problems. So on the surface of the bones is what's called articular cartilage, which is the sort of the blue section that's on the bones. And that's just a layer of cartilage, which is like a shock absorber. And it's very smooth and allows the bones to sort of move on each other smoothly. So all synovial joints have that articular cartilage. All right. Now with the knee, as well as the articular cartilage, you've got these two extra bits of cartilage called the meniscus, and there's a medial meniscus and a lateral meniscus. So you've got sort of two types of cartilage in your knee. You've got the articular cartilage, which is the covering of the bones, and then you've got these C-shaped meniscus that provide extra cushioning between the bones. And only the knee has those meniscus. So then you've got a number of ligaments. In the middle of your knee, you've got the cruciate ligaments, anterior and posterior. And then on one side of your knee, you've got a medial ligament. And on the outside of your knee, you've got a lateral ligament. So then surrounding all that, you've got the synovial membrane, which is what produces synovial fluid, which is basically what's basically feeds the articular cartilage and takes away any waste products. And then around the synovial membrane, then you've got the joint capsule. So there's quite a lot going on there in your knee. We'll just have a quick look at your hip. Again, it's obviously a little bit different. Your hip is a ball and socket joint. So you've got a big ball and a big socket. Exactly the same as your knee. You've got articular cartilage covering the ball and the socket. And again, that's a smooth layer that allows the bones to sort of move smoothly on each other. With your hip, you've got another structure called the labrum, which is kind of like a donut-shaped extra piece of cartilage around the edge of the socket, and that just makes the socket a little bit deeper to make the ball sort of sit in the socket a bit easier. And obviously you can have tears of that labrum. That's got a labral tear. Around all that, you've got the synovial membrane, same as the knee, and that produces the synovial fluid, which provides nutrition to the cartilage and takes away waste products. And then around all that, you've got a joint capsule. So that's just a very quick anatomy lesson. So then what is arthritis, osteoarthritis? And I guess it's a term that has a fair bit of stigma, but really all it is sort of wearing out of that articular cartilage, the smooth layer of cartilage that covers the bones and allows them to move smoothly on each other. So basically, over time, parts of the articular cartilage wear out and basically either become thin or they become rough. And so instead of being nice, smooth surfaces, they're quite rough, and so they don't rub smoothly on each other. And that sort of wearing out of the cartilage is caused by a combination of genetic and environmental factors. So it's partly nature and it's partly nurture. And that's a bit unfortunate because obviously some people work very hard on exercise and fitness, but you still can get arthritis, and some people don't do anything and never get problems with their hips and their knees. So, you know, it's a combination of your genetics and also what you do with your body over the course of your life. So, you know, obviously osteoarthritis is mainly about the articular cartilage or the covering of the bones, but it affects the whole joint. So it affects the bone underneath the cartilage, it affects the ligaments around the cartilage, it affects the muscles. Obviously, you know, the common symptoms of osteoarthritis are pain, swelling, stiffness, and reduced joint mobility. As well as the wearing out of the cartilage, there's usually a sort of a chronic low-level inflammation. So there's basically there's a low-level inflammation in the joint, which is why you know, people with arthritis commonly have morning the joint affected is sore in the morning because of the inflammation, and then once you get moving, the inflammation improves and your knee or your hip feels better. Osteoarthritis usually involves 1 to 2 weight-bearing joints, so it's not usually something that affects every joint in your body, but it's usually 1 to 2 joints. And osteoarthritis is different from osteoporosis, rheumatoid arthritis, and other types of arthritis. Very common condition. 1 in 5 Australians over the age of 45 have osteoarthritis. So very, very common. And obviously the numbers go up the older you get. All right, so on this graph you can see here how common it is. So the most common actually is your hand, so fingers and hands. And as you can see on the red part of the graph, the numbers go up as you get older. So if you're in your 30s or 40s, about 10% of people have osteoarthritis in your hand. But once you get up into your 80s, the numbers are very high. And so then the next most common is your knee, and the least common is your hip. So, you know, If you were 70 years old, might be 10% of the population have hip arthritis, something like 50% have knee arthritis, and something like 75% have arthritis in their hands. So very, very common. So, you know, I guess a big question is, how do you work out if you have it? And this is where I think things have started to change, but still very slow changes. In the past, you know, everybody was keen to have a diagnosis based on scans, but there's a lot of the guidelines, or all the guidelines, are saying you don't need MRIs, even X-rays, to work out if you've got osteoarthritis. Basically, it's a clinical diagnosis. It's based on your examination and where your pain and symptoms are. So I guess one of the key points today is you don't need a lot of scans to work out what the problem is. Most people that I see that come and see me come in with a big bag full of scans, and unfortunately they've wasted a lot of time and money on scans that don't really help them get on top of their problems. So in terms of diagnosing, it's basically, as I say, based on your clinical examination and your symptoms. So, at its very basics, if you're over the age of 45 or 50, if your BMI or your weight is high, and if you've got sort of persistent knee pain or persistent hip pain, and some morning stiffness, and then maybe you have a bit of crepitus, which is sort of creaking and cracking of the joint, and you might be able to sort of palpate your knee or your hip and you can feel it's a little bit swollen, then you've got osteoarthritis. It's as simple as that. You don't need any special scans to prove that. You don't need to have an MRI. You've got arthritis, osteoarthritis. So this quote comes from one of the guidelines, which we'll go through in a minute. A typical knee osteoarthritis diagnosis can be made without requiring further investigations if a person is aged 45 years or older, has activity-related joint pain, has morning stiffness that lasts less than 30 minutes, has crepitus on active motion, has bony enlargements with no detectable warmth. So you don't need X-rays, you don't need blood tests, you don't need MRIs. It's just based on that physical examination. And unfortunately, most people are still spending a lot of time getting scans. So I guess if you do have a scan, really the only scan that you should need is an X-ray. You don't need to get an MRI. But as you can see on this picture, this is a picture of a knee, and you can see the one side is the lateral compartment, which there's a lot of space between the bones, and on the other side is the medial compartment, and you can see that's quite narrowed. And obviously that's just showing the bones, but in between the bones is the cartilage. And so if there's no space between the bones, then you can easily see that that person has medial compartment osteoarthritis. And that's just based on a simple X-ray. You don't need to then go on and have an MRI, but unfortunately a lot of people still do that. So the next slide here, this is an interesting one. Unfortunately, osteoarthritis is very common with other conditions. So they talk about comorbidities. So some people, you usually don't have one problem and that's it. It's usually comes with a combination of other issues. So you can see here from this slide. So the blue is people with osteoarthritis and the green is people without osteoarthritis. And so if you've got osteoarthritis, about 40% of people with osteoarthritis will also have a back problem, but only about 20% of people without osteoarthritis have a back problem. And mental health problems are the same. Osteoporosis. If you've got osteoarthritis, you're about 20% of people with osteoarthritis have osteoporosis, but only about 5% of people without osteoarthritis have osteoporosis. So again, as I said, the comorbidities are high. So osteoporosis goes with all these other conditions, asthma, diabetes, and the list goes on. So it's not usually seen as an isolated one-off condition. All right, so I guess the big question then is what can you do about it? What sort of treatment options are out there? And this is a diagram is the GLAD pyramid, and so what the GLAD has done is divided it up into 3 parts, which is basically first line treatment, second line treatment, and third line treatment. And so first line treatment is the green at the bottom, second line treatment is in the middle, and the third line is at the top. And so basically the research is showing that all people should access first line treatment first. Once they've started that, then they can look at second line treatment. And then if they've tried the second line treatment, then they can move on to the third line treatment. All right, so it should be in that order. So it should be first, second, third. So everybody should do first line, some should do second line, few should do the third line. And again, unfortunately, that's not the path that a lot of people go down. So in terms of first line treatment, and again, these guidelines come from the Royal Australian College of GP General Practitioners guidelines for the management of hip and knee osteoarthritis, and basically first line treatments. And so this guideline is what all GPs should be advising for their patients. So the first line of treatment should be education, which is what you're doing now. There's strong recommendation for land-based exercise, which is basically strengthening exercises, and strong recommendation for weight management. So basically the key starting point for everybody with osteoarthritis should be education, exercise, weight management. All right, sounds simple, but the problem here is that it's not actually happening. So basically, the guidelines for GPs are that all patients should be recommended for those 3 things: education, exercise, weight control. But unfortunately, GPs are more likely to send people for imaging or to see a specialist than they are to send them to see a physio for those 3 things. So unfortunately, those guidelines aren't getting through. All right, so once you've had a real good crack at the first line treatments, then you can move on to some of the second line treatments. And not all people would need to do that, but some people should move on to those second line treatments. And again, these guidelines are from the Royal Australian College of General Practitioners. So you can the sorts of things that you can look at are things like hands-on treatment, like massage, manipulation, maybe some walking devices, maybe a knee brace. Maybe a steroid injection. There's some evidence that a short-term benefit of having a cortisone injection. These are all second-line treatments that that are reasonable after people have tried, had a good go of the first line treatment. So these are the sorts of things that have some evidence, not as strong as the first line treatment, but some evidence that some of these things may help, like a cortisone injection, maybe a brace, those sort of things. All right, so those are the second line treatments. All right, so if you've had a really good go of doing the first line treatments and the second line treatments, then and you're still having problems with your hip and knee, then a few people then should move on to the third line of treatment, which is surgery. And again, the Royal Australian College of GP guidelines for management of knee and hip arthritis is do not refer for arthroscopic procedures. All right, so again, 20 years ago, very common for hip and knee arthritis, but the guidelines are very clear around the world that arthroscopic cleanup jobs of hips and knees is not helpful, and in fact may cause the joint to wear out faster than if you just leave it alone. All right, so the other side of it is considering joint replacement surgery for severe disease when all conservative options have failed. All right, so if we just look at arthroscopy for a minute, arthroscopy is basically where they go in with a camera and they just clean out the joint and trim away the cartilage, smooth everything out. And again, that has been a common treatment in the past, but as I say, osteoarthritis treatment guidelines around the world recommend against arthroscopy. And the reason why it is because it doesn't work. And so this study came out about 20 years ago and basically looked at two groups of people. One group had an arthroscopy and the other group didn't have the arthroscopy. And this graph sort of shows it very nicely. If you look at all the groups at the end of 18 months to 2 years, whether they had the procedure or didn't have the procedure, they basically ended up at exactly the same point. So having the arthroscopy made no difference over an extended time period. So if anybody says to you, well, just do an arthroscopy, then you should say, no, thank you. So here's a graph looking at the number of arthroscopies that have been done in Australia. And as you can see, the research came out early 2000s, and then the number of arthroscopies kind of skyrocketed for a while. But since about 2015, the numbers have really started to decrease as the message has got out there and everybody's getting on board. It's still too high, it should be 0, but the numbers are starting to come down, which is good to see. Here's another graph showing the the drop in the number of arthroscopies since 2012, and it's basically gone from about 500 services per 100,000 people to about 200 over that 10-year period. So the numbers are dropping, but as I say, the numbers should be virtually 0. So arthroscopy is out. But joint replacement, if you've done the first line, if you've done the second line, then and you're still having problems with your knee, then total hip replacement or total knee replacements are possible treatments. So total hip replacements, about 95% of people report a positive outcome. So again, we're looking at quite high numbers. Very successful surgery, and the recovery tends to take about 3 months after a hip replacement. Knee replacement, the success rate's about 80%, so about 4 out of 5 people are happy. Unfortunately, about 1 out of 5 are either no better or worse. So that, I feel like those numbers are fairly high. And the recovery tends to take about 6 to 12 months. So often people get to 3 months and then still in quite a lot of pain. So you need to understand that knee replacements are less successful than hip replacements, and the recovery from surgery takes a lot longer than hip replacements. This graph's a good one, looking at knee replacements by age. And as you can see, the different lines are different ages. And basically, the point of this graph is showing that the younger you are, the more likely you are to have a revision or have it redone again. So if you're under 55 and have a knee replacement, within 9 years, about 10% of those people will end up needing to have it done again. If you're over 75 and you have a knee replacement, only about 2% will end up having to have it done again, all right, in 9 years' time. So the message there is, it's not true to say that, you're better off to have it younger. It does seem that people, if you can get to about the age of 70 before you're considering it, that's going to be better than if you're in your 50s and 60s, because it's more likely that you're going to have to revisit it again within the 10-year period. The end result of the Royal Australian College of GP guidelines for management of hip and knee osteoarthritis is we strongly recommend offering land-based exercise and weight management for all people with hip and knee arthritis, regardless of their age, structural disease, functional status, or pain level. So regardless of how old you are, how severe your symptoms are, how severe your pain is, all people should do that first-line treatment of exercise, weight loss, and education. There's some conditional recommendation for a cortisone injection and strong recommendation against arthroscopy, stem cell injections, and viscose supplementation, which is another type of injection that I'll talk about in a second. So that was the Royal Australian College of GP guidelines. These are the osteoarthritis of the knee guidelines that came out in 2024 from the Australian Commission on Safety and Quality in Healthcare, which is basically a group of researchers that pull together all of the research and come up with these quality statements. And they were quite similar, about imaging is not routinely needed, education is important, physical activity is important, weight management is important, medication that I'll talk about in review in a minute, and surgery is kind of a last resort. But the one that I kind of really wanted to touch on was the recommendation for the use of medicines. And as I said, for corticosteroid injections, they're approved as an adjunct short-term treatment for pain relief. Long-term use is not supported. And all other types of injections are not recommended due to evidence that they provide no benefit and have significant effect. So things like PRP injections, Synvisc injections, stem cell injections have all been tried and offered, but they have been shown to not be effective in the management of osteoarthritis of your hip and knee. So please don't let anybody offer those to you, because they're basically a waste of money. All right, just quickly, we'll just talk briefly about the GLAD program. So the GLAD program is, the GLAD stands for Good Living with Arthritis in Denmark. It's a exercise program that came out of Denmark and then has sort of gone around the world. It's been in Australia for about 10 years. It's run through La Trobe University in Melbourne. They do all the training and the research in Australia. And then different physios practices, you basically get trained to run that program and then all the data goes back to La Trobe University. So it's not that difficult. There's kind of 10 sort of basic exercises in sort of groups of 2, so 5 lots of 2 exercises. The program that we run at the practice runs for 10 weeks, 2 sessions a week. The session takes about 60 minutes. It's quite easy to adapt it to a home or gym. So some people come and keep coming. Some people come and learn the exercises and take them away. I don't really mind what you do as long as you're doing it regularly for 2 sessions a week for about 60 minutes and ongoing. You will likely get benefit from that. Here's a picture just looking at where we run the GLAD program. So as you can see, there's people doing exercises, some equipment, some you don't need too much equipment. There's a couple of other pictures of people on leg presses and reformers. So we do use a bit of equipment, but a lot of the exercises you can do variations at home. So GLAD Australia produces an annual report every year based on the research that they do. And again, just without going into too much detail, as you can see, the average people that do it, their pain levels go down, their medications go down, quality of life goes up, and their physical activity participation goes up as an overall thing. And then on the right-hand side, the one I quite like is, again, GLAD seems to be good at moving people away from joint replacement surgery. So basically about half the people that do GLAD who said they desired surgery at baseline had not received the surgery and no longer desired surgery 1 year after starting the GLAD program. So that's not saying that those people would never have surgery again, but half the people are sort of moving away from surgery rather than moving towards joint replacement surgery, which is a good thing. All right, so we're almost done. I guess the key takeaway message for me in terms of the size is this load versus strength issue. So basically, really that's the basics of what it all comes down to is, if you've got a sore knee or a sore hip, it's basically how much load is going through it and then how much strength you have in the muscles around that knee or the hip. So if your load is too high, which is usually your body weight or how much activity you do, and your muscles aren't strong enough to support it, then of course your knee is going to be sore. So it's very easy when you come and see us and we put you on the leg press machine and see how much weight you can push on the leg press machine. Say you weigh 80 kilos and you can only push 40 kilos. Then every time you're going upstairs, every time you're getting off a chair, you're basically trying to push 80 kilos, but your muscles are only strong enough to carry 40 kilos. So, of course, your knee or your hip is going to be sore. So the whole idea of GLAD and these first-line treatments is to reduce the load going through your joint and increase the strength of the muscles around that joint. And if you do that properly in a slow, progressive way, then your body will feel better. So that's the take-home message: load versus strength. And again, these are some of the barriers that sort of stop people from getting the results that they want. So sometimes the patients are the barrier. So often the patients are looking for this silver bullet. It's kind of a quick fix, like one of these injections, like an arthroscopy. They're not willing to put the hard work in for long enough. And so, they just don't persevere with the program for long enough. And sometimes people are put off by poor results from exercise in the past, and that we see that a lot. And usually that's people that just been sort of pushed too hard, too quickly into the, or maybe the wrong exercises. Sometimes the problem is with the physio. The physio is not following that GLAD pyramid of the first line, second line, third line treatments. Maybe trying to do some hands-on treatment or some bracing before you've actually done the exercise. Sometimes the physio is pushing too hard too quickly, so that just flares it up, and then the patient just gives up. And sometimes the problem is with the referrers, as I say, they're too quick to refer patients for scans or injections and surgery when they're not even following their own guidelines. So I guess my key point there would be, make sure you do the first line treatments properly, which is education, exercise, and weight management. Please stay away from arthroscopy. Please stay away from injections. Please stay away from lots and lots of scans. You're really just wasting your time and precious money on those things that have been shown in the guidelines around the world to not be effective. All right. I think that's all I wanted to talk about. All right. So I'm just going to stop sharing now. I'm going to